Welcome, everyone. Thank you for coming to this webinar. First thing I want to address is it probably will run over an hour. When I was putting this together, I found it starting to mount up in time pretty quickly. Maybe I should have chose the top 8 things, 7 things, but we're going to cover the top 10. It's probably going to run over an hour, hopefully no longer than like an hour and 15 minutes, hour and 20 minutes. But let's get going. Okay, so the first thing I want to do is I want to thank Microdental for sponsoring everything. Great laboratory, great bunch of people, and I want to thank them very much. Also want to thank our sponsor, our other sponsor, Bisco. Bisco is generous enough to give a 20% discount on products if you place an order by the end of the year, which is really generous. Just use that promo code below and you'll get it. So thank you, Bisco. It's very kind of them to do that. So this is the webinar right here. You know, what do we have in common with Spock? And how did Leonard Nimoy become Spock? What does that have to do with dentistry? Well, the history of Leonard Nimoy is pretty interesting. He's a very creative guy. He was a photographer, an artist, everything like that. But he was very much a very classically trained actor. And he did not want to do anything but classical acting. Well, one day his manager gave him this script of a TV show. He started reading it and he thought it was garbage. It was about some alien space movie show thing, and he had to wear funny makeup and kind of tossed it on his living room table. Well, his wife picked it up, she read it, and then she approached him. And this is what he said. She said to me, will you do something that scares you? And he did it. And till this day, until his dying days, he was still Spock. He was still appearing in the movies. Very successful career because he took a chance, because he went out of his comfort zone and he did something that probably scared him. And that's kind of my question to you people. We've all done stuff out of our comfort zone, especially in dentistry. There's so many things, especially if you're going to get into surgeries and whatnot. But cosmetics is so broad and so all encompassing. I mean, no one is not a cosmetic dentist if you think about it, right? I mean, we don't want to put in an ugly crown. We don't want to put in an ugly filling. So we're all cosmetic. It's just to what degree are we going to embrace it? And I know for me, ever since I put my first crown in the mouth in dental school, a PFM, I thought to myself, can I do better? And so that's been my whole drive, my whole career, is to do better. So what are we going to be discussing? The 10 things are, I want to start with the initial visit, and this is how I approach things. So, hopefully you can learn a little bit, or maybe learn not what to do. It's up to you. Imaging, laboratory communication. I'm going to talk about some digital tools I use, facial aesthetics and smile design, occlusion, prep design, temporization, and adhesion. And then finally, a little wrap up about your practice or little things about how I handle my practice. So here we go. Bruce Lee has a great quote. And his quote is, before I studied the art, a punch was just like a punch, a kick was just like a kick. And before I studied veneers and cosmetics, a veneer was just a veneer to me. After I learned the art, he said a punch was no longer a punch and a kick was no longer a kick. And after I learned about veneers, I thought, oh, veneers they're so different. They're prep different, everything's different. But you know what? After 31 plus years, after I think maybe I understand it a little better, a punch is just like a punch and a kick is just like a kick. So veneer is just a veneer. And it's this understanding, and it's really nothing special, but it leads to simplicity. And I can sit here and talk to you about the intricate details of prep design and facial aesthetics and, all that kind of stuff, but is that really going to help you? Because I firmly believe that, we have a long laundry list, say, of smile design. We don't need that laundry list. If you really know what you're doing, it's only like if you get the top 2 or 3 or 4 right, the rest will be fine. But we concentrate on all these little things, I think, too much, and that's just the nature of being a dentist. We concentrate on really the little stuff a little too much. And otherwise, when I was in the middle phase, I think, of learning the art, I used to extrapolate and give every infinite detail I could, maybe to impress people. But it really doesn't help anyone understand. So my goal is simplicity in this program, to give you kind of the Cliff Notes version of things I understand and things I apply to this day. So let's talk about the initial visit. You know, setting the stage when a patient first comes in, you know, we used to make it quite an event. You know, they get the big tour of the office, they walk by every plaque, and you know, the office staff brags about me and blah, blah. I sit in my office in the meantime, twiddling my thumbs. Then they walk into a consultation room, they talk, and then I go in the grand introduction. Over the years, we've kind of done away with that. Now we bring the patient right into the operatory. I get the chart. I've looked at it before. And I walk in and I introduce myself. And I grab a seat. And the first thing I do is I sit down next to them. And one big thing is I sit down a little lower than their eye level. And that's because if you think about overbearing dominance, if I'm over them talking or higher than them, it's like I'm in a dominant position. I want them to feel dominant. I wanted them to feel in control of the situation. So I always sit just a little lower. And I look at them, how are you doing? You know, did you find the office? A little few pleasantries. And then I ask them, how can I help you? And then I do one thing that's critical. I listen. I listen to them. I don't start, as they talk, I don't start thinking in my head of all the things I want to tell them and impress. I know this, I know that. Oh, we can take care of it with this. No, I don't do that. I listen. Because a very interesting thing about the word listen is silent and listen are spelled with the same letters. Think about it. We often don't listen enough. We're always trying to talk first, and we shouldn't. We should listen to what they want. But the truth is, well, maybe they don't know what they want. But don't be this guy, please.
All right, you have two choices. A, you can spend the rest of your life with your wife. Or B.
Okay, I know I'm in trouble when I get home, but you know, hey, that's just the way it is. We want to do that, right? We want to, right away, we want to talk. Don't bother. And really, what is the most important thing to find out when you're listening to them? What is the most important thing to find out? There is one important thing, and it's you want to find out what they don't want. You know why? Because they really don't know what they want. They just don't know. They think they know, but they don't. So that's what you want to find out. You want to find out, oh, my friend had veneers, they're big white chiclets. Well, okay, don't give them big white chiclets. You just found out one thing. It's what they don't want. I'll tell you what they do want, though. They want to build a rapport with you. No one's going to spend money in your office if they don't like you and trust you. Bottom line. No fancy anything is going to make a difference. If they don't trust you and like you, it's not going to happen. So build a rapport. And they really only want to know two things. They want to know if you're the person for the job and what they could look like. How do you tell them what they could look like? Well, that's why we do imaging. I've done imaging myself for 20 plus years. I found just a really easy technique so many years ago, and I still use it to this day. It takes minutes. Sometimes I can do it right in front of the patient and they think I'm some artist. So you're enhancing your perception to them. So what is the purpose? First, you got to remember to think like a patient, not a dentist. Get the dentist hat off and think like a patient. What do they want to see? You know, what do they want to really, really see? And then down the line, think about, well, what do you want from the imaging? For me, and I think probably for you, you want to know what the final result should look like. So you can then work backwards to get it there. Okay. Bottom line is, they just want to be wowed. I can do this imaging in a couple of minutes, right in front of them. They just want to be wowed. A real simple technique I use is I take some smiles I've done over the years, or you can grab some off the internet if you don't have a big enough portfolio. Not a problem. Extract the smiles off the faces. That's all you're doing in simple photo editing software. It's easier than, you know, a double click. It's so simple. Then when a patient comes in and you take a picture of them, you kind of fit the smile on them that fits best for their face and for their lips. So say it's this one. Already it looks pretty good. Then you just have to do one little enhancement or adjustment to the color, which is desaturated. The gums are way too fiery and pink. Just desaturate them a little bit. Now it blends perfectly. And guess what? Now I can print this out and give it to them. But you know what I need them to think right now? I want them to think, wow, I look good. Because then you succeeded. Now you have their interest. So with photo imaging software, there's basically two major players. Photoshop we all know about, and there's something called Affinity Photo. Photoshop is about $10 a month. You rent it, you never own it. Affinity Photo is a $50 one-time purchase. I've owned most of the Affinity apps that the company comes out with. I think they're amazing, and here it is. To me, it's just as good as Photoshop. So Affinity Photo is, and this is a patient I actually just finished. She was so excited about the imaging. So I took this picture of her, I brought it in, and I have this photo library. This is a separate file of just smiles. And if you look right here, it says Imaging Master. I have that already on my computer open up. So now I take an appropriate smile of that selection. She only wanted to do 4 teeth. I erased the other ones with this simple eraser tool. Okay, and then I color corrected it. And this is her result, all within a few minutes right in front of her. Then I just printed the picture out. I have a template all ready to go, and I just printed it out. So this is what my template looks like that I give my patients. She was so excited, she pretty much ran up to the front desk to schedule. I mean, I can't ask for a better scenario. So how do you do it? I mean, nowadays doing it on the iPad, doing things on the iPad is so much easier. It's so portable. So on the iPad, the first thing is setting up a template. I use Keynote, the presentation software, which I'm using right now actually to do this. And I have these templates ready, already opened up. I then go into my choice, my app. Now I could choose the same Affinity Photo. It's available on the iPad. I choose to use a drawing program called Procreate. You can see my drawing here of the tree. I just left drawing in it, and it's so much easier to do actually imaging. So what I do is I have this file of those teeth. I then import the patient's photo. I just took it with my iPad right in front of them. I then select the teeth. And what I do is I actually just want the upper teeth. So there's a quick selection tool in Procreate, easy to learn. Just select, wipe over the teeth, it selects them. And then you just copy and paste it. And now you have that selection for your taking, really. So now what I'll do with those teeth just selected, I'll go up and I'll copy it. I'll go back to his photo, and now I'll put it on his face. And now I'll resize it. I'll do whatever I need to do to kind of get it to match. And it's so funny because you can be right in front of a patient with your iPad doing this, and they think you're like Picasso. And you're just measuring little things. I want to stay probably from canine to canine a certain distance. I'm then going to affect the opacity so I can erase whatever's above the lip. And now I'm going to change the color, and that's just what we call a curves adjustment. It's this subtle S is all you have to do in this graph all the time for almost every case. And it kind of desaturates, a little translucency to the teeth. Save the file. So now you have the before, you have the image. You go back to your template, throw on the before, resize it. Go back into your photos on your iPad, get the after, resize it. And now from the iPad, I'm just going to go up to the menu and print it. And I can show my patient, but sometimes I have my office manager walk in with the paper and just give it to the patient. It's a more profound kind of experience for them. And there it is, it's ready to go. Very simple, very easy to do. You don't need any fancy dental apps or anything like that, but it's so powerful. But have your templates ready. Have your file with all those different smiles and have the template ready, and it's seconds, it's minutes, it's so easy. Also, this is a great way to talk to specialists. Here is a case where I did the picture before. I just imaged where the teeth should look longer after crown lengthening, and then I gave her, this is what it could look like after. And working with the specialist is key. I use periodontist quite a bit. And you know, you have your surgical template, go from here to some microveneers. So You know, Micro did a great case with this. This is a much older case, actually. This is very old. And I really didn't even think the patient was going to do it. This is an old Polaroid. This is how old this is. This is an old Polaroid. I didn't think the patient was going to even do it. And she did it. And it turned out great. And she loved it. So how do you get that final result? It's all with the communication with the laboratory. And that's always been the key. Communication. Communication everywhere, to the patient, to the lab, everywhere. It all starts with making a very good impression. What I mean by that is take a very good impression. Now, if you're digital, we'll talk about that in a second, but I don't use alginate. I only use polyvinyls. For my initial impressions, I use a medium body, a monophase. Key is retraction of the soft tissue, dry everything thoroughly, inject in the mouth around the hamular notches, all in the mucobuccal fold, get your tray, seat it, they bite down for 4 or 5 minutes, and you get a beautiful impression every time. And if you're mounting your cases instead of a Facebook using HIP plane, you have your hamular notches and your incisal papilla markings in this impression. So it's a great technique to use. I haven't used alginate for decades because I want something I can have for a long time and I don't have to worry about like one pour and I'm done, okay? Cheek retractors, Ultradent has these new umbrella retractors. I find them really useful too. And that was Optrogate, which you saw. So as far as scanners, I've been using scanners since 2004 or 5. My first was with the Cerac system, then the E4D system, and the Medit I70. I've used the Itero. I've used other ones. This one is from Microdental is selling this, and I actually love it. It's a really small, very ergonomic. It's got some low-grade features, small little laptop. The training it comes with the system. I really love it, and if you don't have a digital scanner, I would probably give this a try. Because it's really a nice little piece of equipment. And there's so many out there, but this is one definitely worth looking at. Right now, I was talking to them and they have some special promo with the saving on restorations and all that stuff. I would check with Micro for their details, but like I said, been a really, really great addition to my scanning process. As far as scanning, I don't always scan like full arches and things like that, but it's really great study models and stuff like that in the beginning. So now that you've had your models, and one of the things you want to do is how are you going to communicate the horizontal of the smile to the lab? Well, you know, poor man's face bow is your stick bite. It's been around for a long time. It's probably one of the most underutilized things. I mean, I'm not saying don't do a face bow or do something else. I'm not saying that at all. I'm just saying a lot of times those things are overkill if we have a patient with a solid dentition, no underlying problems. This is probably a pretty easy way to go. The key is to have it perpendicular to the long axis of the face. We used to talk about go by the eyes and go by all different facial landmarks, and it's ridiculous because faces are asymmetrical. So if you use this guy's eye line and it's canted, so is your smile. So make sure it's perpendicular to the long axis of the face. That's probably your best go-to. And there are other tools. There's symmetry. This has also been around for a while. It's a really great thing. The vertical attachment comes off, so when it goes to the lab, it doesn't get bent or broken. But this is also another nice piece, besides if you have to go to a face bow or something else. So what goes to the lab? It's important to have a system. I have a lot of systems in my office so we don't miss anything, and that's key. I send photos, and why don't I send 10 or 12? Because it's not needed. And why don't I send a smile? Well, you're doing a smile, Pescatore. Well, you know what? They can blow up a picture of that face and see the smile. I don't have to send a separate picture. It's all about simplicity and sending the minimum to get the maximum. Here are the impressions in my fancy face bow. And imaging, always send them imaging. If you've done imaging, it's always good for that technician to kind of see what you're expecting, or especially in the final result. And on your lab slips, here you go. These are the key portions. Now, yes, you can write 2 pages on your lab slip, but if you want to, make your technician not like you, please do it. If you have to communicate that much, then either you probably don't know exactly what you want, or your technician and you do not know each other well enough. Because if you think about your technician has 100 dentists that they're getting cases from all the time in the lab, they're not going to read 4 pages from every dentist. So figure out the key things to give them. And a lot of things visually, like pictures and one, are better than a paragraph. So think about communicating that way to them. And what you're going to get back is you want what? A diagnostic wax up. This is your key. This is your key. I always tell my patients, unless you have a specific wants and desires, I'm going to design your smile. And I want that diagnostic wax up because I'm going to use it later for the temporaries. I want them to think I'm designing it first. If they kind of come in with their own idea, I'll entertain them and then I'll probably still do what I want. Next is digital. This has kind of been an evolution. It's both a great thing and can be a bad thing. It can be abused. This is the way things are going. I've always been digital or 3D for a long time with other things. So coming into this wasn't that hard. I was just trying to figure out the best way for me to utilize it for my needs. In the dental space, you know, the 2 biggest resin printers are from Formlabs and Sprint Ray. For me, these are overkill. But if you are doing, you know, implants and you need surgical guides, if you are doing ortho retainers or, you know, aligners or things like that, definitely invaluable. But you have to remember, you have to do enough of this stuff. If you're doing 1 a month, I don't know, is it worth it? These aren't cheap. You also have to think about, what are the maintenance costs? What are the materials cost? If something breaks down, how much does it cost? I talk to you from experience of owning in-office CAD systems and other systems for a long time. There are those hidden costs you don't really think about, but when they hit you, there goes your profit. So for me, these aren't for me. I use different sculpting tools also. I use some on my computer, probably 25% of the time. I'll show you what I use most of the time. But on my computer, there's free software called Blender. Blender's a professional, so to speak, 3D program. But there is I believe he's a technician in Australia, and he came up with all these modules to turn Blender into dental software, to turn it into like a 3 shape. I've bought a few of his modules, which are cheap, like $79. I mean, and you can do anything. You can actually, you know, set condylar inclinations and have your 3D models move in 3D. I mean, the guy is really brilliant. You can also get one of these little graphics tablets. Instead of a mouse and clicking, you can have a pen and move it that way. It's a little easier. But then on tablets, between your iPads and your Samsung tablets, there's an app called Nomad. Nomad is a sculpting app. It is amazing. And it allows me to do stuff just like that. So in Blender, here basically is a scan. I actually took a before and actually waxed this up in Blender for a patient. But this is sculpting tools. If you've used in-office CAD/CAM, you know, basically that's what you have at your fingertips are sculpting tools when you're going in to adjust the proposal. Very valuable. Nomad on the iPad is just, it's really amazing, amazing. There are many professionals in movie industries using it. These are some models I scanned, put into Nomad, and I'm going to do a 4-unit diagnostic wax up. I duplicate the upper model first. So I have obviously a reference, and I don't want to disturb. The first method is just direct manipulation, where I'm just moving pieces of this model like clay. And if you see, there's some masking going on. That's what the black marks are, so I don't move certain parts of the tooth next to it because it's easy to move teeth and not know it. But a very simple, easy thing to do, sculpt. I can literally do this during my lunch hour, have the wax up printed in the afternoon, and prep the person the next day. I enjoy this. Now, some people might say, well, why do this? Why don't you just direct mock it up in the mouth? Oh, and by the way, here's a second way where I actually have a tooth template, where I actually made these teeth. You know, I'm a 3D geek, what can I say? I made them, put them on the model, And that's another way to do it. Kind of like how the in-office CAD/CAM does it with these ideal restorations you kind of put on your prep. But some people would say, well, why not direct mock-up in the mouth? I can do that in a few minutes too. Well, you could. That's what you want to do. I just don't waste my chair time like that. This is spare time. I've never lost a patient. I know people are going to say, well, I get the patient buy-in right away. I've never lost a patient doing this over lunch or doing it right in front of them. It's a very quick, easy process to do. So this is how I do my printing. And my equipment is a little cheaper, a lot cheaper. This is my setup. The resin printer is $230. It's actually cheaper now because the company has come out with a couple other different versions. You have to clean and then cure the resin. So my cleaning and curing station is 130. The new version of my resin printer is now 4K. They actually just came out with 8K, I believe. So you're talking microns are very low, below 30 now. I don't print my models anything lower than 50 because it's not necessary. But I just print models. That's all I'm printing, and that's all I need to print for what I do. The resin is very cheap. I one time bought the most expensive one, the $70 one, wanted to see the difference. They put these photos in it. I thought, oh, it's going to be so much different. It's not. So I buy more or less the cheapest gray, and it works perfectly. So what you're doing is you're pouring the resin in this little vat. And of course, resin's toxic. You don't want to breathe it all day. So well-ventilated room, wear a mask, wear gloves. Once you do that, you plug in your model, or you sync up your model. Your model files come, and you can see on the bottom there, those little drawings here, you can see it's printing it in layers. And after it's done, these 3 models took about an hour to print. And after they're done printing, that's it. You then take them off, and I bought this additional flex pad. This little metal pad is it's a magnetic pad, and it flexes. So there's no scrapers and all that other stuff. I just flex it, and they pop off in the alcohol bath. It's isopropyl alcohol, 90+%. I turn it on, it whirls it around, it gets all the excess resin off. I then put it in the curing station for about 6 minutes, standing up and laying down. And then I have my before and after. So this is the before, and there's my after, my diagnostic wax up, which I use, for my temporaries, my prep guides, and all that other stuff. So I've just found this very helpful. And plus, I like doing it. I guess you have to like to do it. So that's what I do. And also, it's just not for diagnostic wax up. I've also used this for hybrid prosthesis. I remember one time I had my technician send me the hybrid prosthesis they were going to print, and I didn't like it. I thought it was too much anatomy, too many rough edges. And so I actually brought it in Nomad, and I smoothed things, and I adjusted the tissue height. And I did all these things to kind of make it look maybe more American, that cleaner look, not these worn edges. I sent the STL file to my technician, and they made it from that. So you can really do a lot of things if you just think about it, and your technician will send you the file. It's so nice and easy to do. So let's talk about facial aesthetics and smile design. One thing we're dentists, so we're taught to look at millimeters, right? We're taught to look at the little nuances all the time. But you don't want to do that with facial aesthetics and smile design. We're taught to look at, we go to a forest, and as a dentist, you go up to the tree and you look at the bark. I mean, that's what we do. We analyze the bark when we should be looking at the big picture. Big picture, and then go into the small details. It's never the opposite, but we're taught pretty much the opposite. So over the years, I've worked with different modeling agencies and things like that. And I've been fortunate enough to work on a lot of models. And one of the things about working on models is you're given a great template to work with, a great canvas to begin with. So really, my attitude was, I just can't screw it up. And how I screw it up is I make a smile that doesn't fit their face. What I mean is I make a smile that dominates. Now, if you look at her, a beautiful woman, you're not noticing her teeth so much. You're just noticing her beautiful skin, her beautiful hair, her eyes, facial features. The teeth just are part of it. Oh, you think, oh, of course she has great teeth, but it's not the main focus. That's really the goal of cosmetics. It's not to put in a bunch of white chiclets, because really, if you think about it, a beautiful smile should exist to enhance the face and not call attention to it. It really should disappear and enhance the beauty. That's the key. So that is the goal. But let's look at some principles. Sorry, I'm thirsty. And the principles are things to think about. But again, we also have to realize, how much control do we really have over facial appearance? So I alluded in that little teaser video for this webinar, I alluded that there's one book. This is it. This is the classic book, Fundamentals of Aesthetics by Claude Ruffinac. This is the book to get. There's not been a book, and this came out in 1990. I remember I bought it in 1990, and I've been reading it ever since. I'm a slow reader. But it has everything in this book you'll ever need. Sure, there's been new books that have come out on facial aesthetics and smile design, but everything is out of this book. There's nothing new. It covers everything. So if you know this book, and if you read through it, you will know everything. But you also know that a lot of those little details are really encompassed in a bigger overall picture. So when we look at a full mouth rehabilitation that actually changes facial aesthetics, well, we kind of expect that, don't we? I mean, if I'm going to treat this person and open their vertical, restore upper and lower teeth, let me ask you a question. Was that my goal? No. My goal was to give her a stable TMJ complex, make the muscles happy, good breathing. The facial aesthetics will come. So the idea of facially generated treatment plan to me makes no sense. I'm not a plastic surgeon. We get to work on the inside and affect the outside. But I don't treatment plan, I want to get her this open. I don't look at her face and go, well, these are the thirds of the face and I need to open her this much. No, 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 no. We will enhance the aesthetics if we do it right dentally. And, you know, even Claude back in his book talk about these thirds way back then. I like these little terms like sensuality and all this other stuff. And there's a lot more drawings in his book, which actually I like personally better, but it's a timeless book. Get it if you can. And also in those imaging, I also show them what they could look like if their bite was opened. Because if a person comes in like this, you can obviously see that lower face height is just squished. She needs bite opening. So you can actually image this very easy too. And so then I look, well, you can look like this with veneers, but we're not fixing your bite. But if we fix things, it's wow, she looks different. So because I fixed her dentally, she looks better facially. And if you really, really want to do facial aesthetics, get into Botox and fillers. I actually really enjoy Botox and fillers. And when I can get a guy like this and do a full mouth reconstruction, and I just did Botox on him actually. Boy, more than I ever hoped for, I'll tell you that much. This was one of those areas I was scared for many years to go into. I just was. I have so many plastic surgeons in my area that are so good. I was worried they were going to be a little upset with me. Turned out they weren't upset at all. Some of them actually had referred me patients, which was kind of funny. So let's talk about, you know, the psychology of designing a smile, because there's a few things to think about. And maybe it's because I love art and I still do art to this day, but I look at things like that. And we have to use another part of our brain. This is some temporaries I did on a patient. And if you look at them just straight on, okay, acceptable. But how about if you look at them with a different orientation, upside down? Now maybe I see some things I didn't see before. I see that maybe the neck of this lateral is very tapered compared to this one. Is this smaller than this one? I'm gonna have my technician check it out. This canine is actually either too straight or a little flared compared to this one. I like the way these teeth are versus these. Little things, but it's all because you're using a different part of your brain. It's called the right side of the brain. And it was a book a long time ago by Betty Edwards, Drawing on the Right Side of the Brain. And it actually has an exercise of drawing a very difficult picture upside down, and it's so much easier because your mind doesn't think in at all anymore about what you're drawing. It thinks just the shapes, which is much easier to comprehend. Also, Hick's law. We are so guilty of this in dentistry. We give people tons of options and all that stuff. Well, it takes more energy to make a decision. It's confusing, it's unsettling. We need to give them a direct purpose. This is what I think is best. Yes, these are other alternatives, but this is what I think is best. If you give them more opportunities, if you give them more options or lay out all the possible options, guess what happens? They get confused. And you know what? We do too. So what do you want to do? I think that's where you have to really decide. So some patients you might not want to treat if they're going to let you do less because you don't want to be responsible when they come back and go, I mean, why am I not looking like this? Well, you didn't do this. You got to really talk to your patients. Less is more, definitely. When we talk about smile design parameters, this is very true here. Less is more. If I want to talk about all the design parameters, here we go. I mean, this is a lot of stuff, a lot of nitty-gritty details. You don't need to know this kind of stuff. You really just know, really, to me, there's like one or two things that's the most important. Everything else falls into place. To me, the two most important things are your smile line or smile curve and your axial inclination, or even the midline to a certain degree. Next, after that, incisal embrasures and proportions, because each one of these things gives me many things underneath it. So always look for the biggest idea that gives you all the things underneath it. What do I mean? Smile curve. Look at the smile line. That's a very nice smile line for someone. But what is it, just giving you a smile line or a smile curve? No, it's also giving you the length and position of the front teeth, the overjet, the overbite. Those are very important things too for phonetics and all those other things. So it's giving you many more things. Don't just choose one thing and then you have to go back for many others. This tells you a lot right off the bat. Your incisal edge position, well, that's part of the smile curve, right? And if you have maybe a straight or reverse smile, look at all this negative space. Wouldn't this be better? Look at the lower. You also have these incisal edges, which are irregular. No, they need to follow the curve as well, to a certain degree. And then once you have an irregular smile curve, you'll never do it again because it's so obvious. And it's just one of those things you usually will pick up in a temporary. The axial inclination and midline. Well, the midline, if you look at this guy, his midline's off. Some people will have a midline that's off. And what are you going to do to correct that? You're going to over prep, right? Because you have to shift the midline. You're going to have to take away from some side of one teeth. And you're going to over prep. As long as it is parallel with the long axis of the face, you're fine. Now, the inclination of the teeth, that's the distraction. There's no distractions when you look at this. All the teeth are mesially inclined towards the center. You look at this smile, that canine is out in its own place. That's also a big warning sign for occlusal problems and some other issues too. So incisal embrasures, this is kind of the more artistic part. This is the part where I like to finesse every case. I use my smoothing disc and I'll go in there, create a little embrasure individuality, maybe some incisal edge. But this is the key to getting chiclets, piano keys versus nice natural looking teeth. In your proportions, we talk about proportions. Golden proportion has been talked about forever. Pretty much everyone in here probably knows about it, but it's a relationship. And the big picture relationship is that from the front view, the width of the central is equal to the width of the lateral and the canine. In this case, it's not. It's a little wider. And I prefer it because if you look at golden proportion, this is the correct. Everything is related to the lateral. Golden proportion is related right off the bat on an error. Because besides the wisdom teeth, what is the tooth in the mouth most varied in size? Lateral incisor, peg laterals, we have names for it. So you're going to base a ratio off of this tooth. So you have a 1 to 1.618 ratio, and then the canine is 0.618. So just, these two combined equal this. Again, big picture. To me, that's not the way it looks. I don't want to, that's not a youthful look. That's not what people want. And I guarantee you, go in a bunch of dental publications, look at front view smiles and measure this. Guarantee they're all this lower one. They're not this. And then there's another proportion that we don't talk about much. And that is the buccal corridor proportion. When you're looking back, besides a tooth that is off an angulation, sides will often throw you off too. You have the width of the canine, which is the transition from the anterior to the posterior teeth. That will appear a certain width. And then you go back to the bicuspid, and if you go small and then big again, visually, it doesn't make sense. What it should do is it should go from the width of the canine to a little smaller, and then you get the proper gradation of size. And of course, there's the tissue gradation as well, which is one of those main things that you'll get. Typically, if you get the previous, you'll get this. And where does this all come from, really? Okay, where does me deciding on that these things are the most important and that everything else will fall into place? Well, I can tell you it's from like over 31 years of experience doing these things. And so that judgment comes from experience. But where did my experience come from? Making a lot of mistakes. So you can't worry about that. You can correct mistakes, but anything you do well now is because you didn't do it well a while ago when you learned. So don't worry about the poor judgments. Just learn from them. We all do. We are not perfect. There's no one on this planet that's perfect. But you strive to be better on every case. I have never, in all my years, whenever I look at a case, I still wish I could do it better. That's how you should be. So let's talk about occlusion. This can be a little touchy for a lot of people. But I will have to say that I do have a love of just learning about facial aesthetics and teeth shapes and all that kind of stuff. But occlusion is very fascinating to me because of all the nuances that can come into play. I mean, I guess that's not something you want to put on your Tinder profile, but occlusion is pretty fascinating. But there are some main goals of all the philosophies. And I'm going to move this off my thing a little bit more. This is my definition of stable TMJ complex, supporting dentition, muscles, balance, airway, patency, facial balance, harmony, all that stuff. That's just mine. And the next thing is not, oh, I'm sorry. That last part was don't introduce any iatrogenic factors. Don't cause any problems. And too often we overlook things, and we do, mostly by putting in interferences. So don't. Just be very careful and mindful of those things. Occlusion reality for most practices is an MIP, which is maximum intercuspation or maximum intercuspal position, whatever you want to call it, is okay with acceptable function and negative headache or muscle symptoms. Most practitioners are not changing the vertical on a routine basis. And even if they are, you should probably include disciplines like ortho and things like that. So really network with good specialists. I have networked with some excellent periodontists, orthodontists, oral surgeons. They are tremendous support, and endodontists too, because I know what I'm getting back and they know what I need. They know what I need, and that's key because you don't want to get around. How many of you have gotten an implant from an oral surgeon and it's like totally angled crazy because they didn't talk to you before? So, get a good relationship with your specialist. But however, most practitioners should be adjusting the interferences, creating balance, all that kind of stuff prior to restoring. And this is probably the most often overlooked issue. And that's those iatrogenic problems that we incur or we put into our patients and not meaning to do so. So what is something they all have in common? They all can work and there's no cookbook. Okay. Any one of these philosophies will work 80 to 90% of the time because of human adaptability and things like that. The problem or the confusion where some people say this is better than this is in that smaller percentage, 10 to 20%. Okay. Dentists should be not thinking about a philosophy so much as or a specific technique, but what's best for your patients. And Eddie McLaren said this. And Eddie's a good guy. Eddie's a dentist and a talented ceramist. And I couldn't agree with this more. I think this is really pretty appropriate. Let me get this off a little bit more. So considerations and tips. Most have a range to open the vertical, and there's no one specific amount, okay? People can adapt, they have a range. And there's really only about 3 reasons, maybe 4, to change the mandibular position. The first is joint or muscle issues, airway issues. You need room for the restorative material, or the 4th could be a combination of some of these, or all of them, okay? What else should we be looking at? Like I said, airway. Airway's huge. Look at the relationship of the front teeth here, anterior teeth here, and these teeth, and then look at the airway. I mean, that's huge. We have to look at airway. Airway is huge. And we know that orthodontists who view growth and development have been looking at this for years. We need to as a restorative dentist. And then there's the, was it Malapati score? I'm probably butchering the name. But, you know, he was an anesthesiologist who wanted to come up with a really great way to classify the difficulty of doing the intubations, right? Great, and now we use it for sleep and just an overall screening process. Facial types. Facial types are interesting because we often think we look at facial types for aesthetic reasons. I don't look at facial types for aesthetic reasons. I look at it for potential problems. You have the brachio, the mesio, and the dolio, or the dolico. Okay, if I see someone who's brachio, look at those masseters. Man, they got hunker strong masseters. They're probably destroying their dentition. Okay, and then you look at more of the dolico, or dolio, I would say. That's a very narrow. I'm a narrow person. They're mouth breathers. I'm a mouth breather. Adenoid and tonsil issues almost my whole life. You're talking major issues. So these are things that you have to look at. Facial types should be indications and red flags for what is going on with their body, okay? And then posture. Posture is something we don't talk too much about. Posture is one of those things that, what are we concerned with posture? We're concerned from here up. But if you think about all the people today that are like this at the computer, I mean, if you don't think they have posture issues that are going to affect the overall complex up here, you're mistaken. And this is nothing new. Again, it's in Claude's book from 1990. He talks about how posture can affect the whole craniomandibular system. He doesn't have the fancy pictures that are in the books today, but he has it, and he talks about it in length. So let's talk about, say, 2 different camps that are out there. You have the physiologic-based, or what we call neuromuscular, primarily toward LVI. As disclosure, I was the director at LVI from when it started in the mid-90s to the mid-2000s. I retired from there to be a soccer coach and Cub Scout leader for my son for years. But it was a great place. It was at the height of, and anybody who's on there who was in LVI in those days, you know, it was just such a phenomenal place. The energy, the learning, it was all great people there. And the people teaching there, Bill Dickerson, who obviously owns it and teaches there, I actually saw him lecture on CBCD scans, and my God, it blew me away. I never knew there was so much to know about those scans, but he impressed the hell out of me. And you have great people there like Joe Henry, Dr. Joe Henry, and Dr. Kevin Winters, Dr. Joe Barton. I mean, amazing educators and knowledgeable people on this stuff. So, and then you have the CR and the CO kind of camp, I want to say. Maximum intercuspal position, if you want to call it, instead of CO. The classic, Dawson, Pankey, Spear, Coyce. I mean, these are, you know, these are names, and for a good reason. So how neuromuscular is based? It's based on tensing. Tensing is using a device to basically flood the muscles with blood, which releases the toxins out of the muscles and relaxes them, stimulates. Then they have the BioPack, which actually measures the muscle intensity. And here it is being put on. It's using objective data to establish the proper position, meaning it's using EMGs, okay? So that's how they do it. I tend, the woman you've seen before, and I'll show you again, She was one I treated neuromuscularly, and I don't think I could have treated her otherwise just because of so many of her other issues. But in Dawson Pankey, we have deprogrammers. I've used Great Lakes before. Then there's the Coist deprogrammer, the Lucid Jig, which is really called the Pankey Bite Stop. And here it is in the mouth. And then the leaf gauge. I've used some anterior bite planes in the past with decent success, some not so. And then I've used the leaf gauge, and I can get an overall kind of guide of where I need to go. Because if they're uncomfortable, there's probably internal derangement. And that kind of gives me an idea of maybe what I need to look into first. And the leaf gauges I get from Great Lakes, they're sterilizable, they're really great. And it's just a diagnostic tool for me. And I've restored some people to it, but most of the time I always hook them up to the TENS to a certain degree to figure things out. And this is what the BioPack will give you. It will give you these readings. It focuses on the 8 muscles of mastication, the masseters, temporalis, sternocleidomastoids, and digastrics. So 2 of each, right? And this is someone who has problems. You can see when they're resting, you have muscles firing, and when they bite, they got a lot of firing going on. But then if you get them in the right position at rest, you have passive. It's not firing at that point, it's passive. And then when they bite, and what I find so interesting about this is that the order in which when they're biting, you see the firing can give you guides to, is something wrong? For instance, if the temporalis was to fire before the masseter, there's an interference going on probably. So that to me really intrigues me. And this equipment really intrigues me for that reason. Then there's something called the T-scan or the tech scan. This is a bite force, and I've seen both camps kind of utilize this to a certain degree, but LBI really utilizes it hardcore in their philosophy. And I really find this also, I mean, some of this computer equipment is really interesting as far as what it's giving you. It's giving you where the force is, and therefore you can adjust much, much more conservatively, because you won't adjust areas too much that didn't need it. You know exactly where to go. So to me, this is something that is very valuable for the clinician. So if we want to talk about, and these are all my drawings and animations, so 100% correct, maybe not, but they hopefully give you the idea. So for the neuromuscular approach, if you have someone with a condyle that's retruded, which is very possible, class 2-ish kind of thing, you hook them up to the TENS, and by relaxing the muscle, the jaw is going to drop and relax. Almost 100% of the time, the patient feels, oh man, I feel so relaxed. I feel like going to sleep. They get tired because it feels so good for once. And then by manipulation of the TENS, and you can hook up the BioPack and check things, you can actually get them into the proper position. And that will put the condyle complex with the disc and everything in the proper position. Sometimes if you need to, especially if you need to open them and stuff, you're going to use something like an orthotic. Okay. And you want these readings. Remember the readings. The goal is the bottom. So in a CR or CO, same thing, retruded, you're going to use something to get the forces off those bacterial teeth. And say you're going to use something like a leaf gauge. And really what it's going to do, it's by preventing those posterior teeth from contacting, the forces are greatly reduced to a great degree. They say, research says up to 70%. I don't know. I think it's 69, 68. But anyway, it's reduced and your pterygoids release, and you're able to what they call passively seat the condyle. And that's really what's happening. You want enough leaves in there so you have about 1 to 2 millimeters opening in the back. And the movement is something like this with a leaf gauge. You put it in, you have them move forward, have them move back, and then bite maybe about 50%, which they say is equivalent to like a swallow force, okay? And you typically will always have a slight increase in overjet. But the idea is that it's seating passively into a, quote, ideal location because the posterior occlusion has been disengaged. And that's it. It's very subjective because you're asking the patient, does it feel better? Or the patient's reporting things. Now, if they have a high pain threshold, you hope you're accurate, right? That's the one thing. And there's also the Lucid Jig, the Pankey Bite Stop. The pink stuff is bite material because you have to reline it. And this is a great screening device, like I said before, for people who have internal derangement issues. And it should be parallel when you're putting the bite material in and having a bite. Typically, a lot of people like to use a whale tail. I have a modified, one of those little modified denture setup things. Like it looks like a whale tail, but it's more just triangular. And they bite on that, and it makes it level with the lower arch. And that's why you don't get any inclines or anything like that. You always are looking for one point of contact and things like that too, not multiple. But if you need a longer phase of deprogramming, then you need typically something like people will go to a Great Lakes or a Coist deprogrammer. I have found these quick splints to be exceptionally helpful, and I don't have a lab bill. So you buy these from Quick Splint, and all you're doing is you are relining that little plastic piece, and they come so nicely packaged. Whoever made these really thought up a nice scenario. So here's basically a little bit of muscle positive, had some muscle aches in some areas. So I tried it in, relined it with some bite material, stuck it back in. It's set, and that's what it looks like set. I cleaned it up, put it back in, and now this is good. Send them home with it, and they wear it. And let's hope they deprogram, and let's hope they feel better. And that gives me a guide. Now, saying they might come back and say I feel better, I probably still hook them up to my 10s and relax stuff even further. But this is a great thing as opposed to getting maybe a Great Lakes or a Coist deprogrammer. I find give me 3-4 weeks of these, and they're probably, they break down quite a bit. But that's all I need, really. So the bottom line is, first do a comprehensive exam, including any needed radiographs and stuff like that. If they're asymptomatic, traditionally we're going to analyze the MIP, and the movements and fine tune prior to doing restorations. If you're doing neuromuscular, you might TENS them, and you're going to use something like the T-scan to look at the bite forces and make sure that they're where you want them to be. If you need vertical opening, or maybe they're symptomatic, a traditional with no deprogramming, I'm probably going to use a leaf gauge most of the time. The one time I don't use a leaf gauge is if they have mobility in the anterior teeth. I know some people talk about if it's a deep vertical, they don't use a leaf gauge. No, I've actually been able to use that a little bit with success. I haven't had too much of a problem, but it's the mobility in the anterior teeth that's an issue. If they do need deprogramming, you have the choice. The Lucid Jig for in-office only. You don't want them to take that home with them. Great Lakes or Coist, or I use the Quick Splint now. So that's what I'm using. For neuromuscular, traditionally, you're going to hook them up to the 10s, evaluate the biopack, make an orthotic, use a T-scan to hone things in, and then you're going to restore, or you're going to do ortho, you're going to maybe equilibrate or restore. So those are the things you're going to do with that scenario. So this case took 2 years. She took 2 years because she had other issues going on. She had implant in the upper right area that needed some work prior to us restoring. I had to temporize the upper left side for some perio surgeries. She wasn't exactly great about wearing her orthotic in the beginning, so I really wanted her to wear it. So once everything got really stable and she was very comfortable, I then restored her upper. The lab made me this lower overlay. It was made out of PMMA. I just bonded it to the top of the occlusals. That kept the tissue healthy. She used a water pick with Listerine in it, and she flushed in between her teeth. Of course, she missed right between the two lower incisors, but she flushed, kept the tissue very, very healthy. And I made her wear this for about a month and a half to make sure nothing was changed, nothing was moved. And then we finally restored her upper and lower. So my recommendation is, if you already have implemented an occlusion workflow, take some entry-level programs at the different teaching facilities. They're all excellent. Again, my experience or my history is with LVI, but you can't deny the benefits of the other organizations for sure. So which one do you click with? That's the key. And don't listen to any negativity about the others or anything like that. Decide for yourself, because really negativity is not a place you want to go, because we all know there's more than one way to skin a cat, right? So, and find the one, and really what you're going to find is I have found, personally, I use sometimes multiple approaches depending upon the patient. So that's your best approach, in my opinion. Okay. Next, let's talk about preparation design. Now, there's some myths. First, I want to dispel. The first is there's only one way to prep a veneer. That's not true. You must not prepare for veneer. You must prepare for the restoration you want back from the lab. That's the key. There's a big difference between that thinking. Okay. Only can be an enamel. That's not true. There's only one way to prep veneers. Well, I said that again. And strictly a cosmetic restoration. It's not true. It's a functional restoration that looks good. Veneer preparation facts. So we know there's no such thing as a veneer preparation. It's an all ceramic restoration. That's it. Just keep it simple. There's so many factors that determine the final preparation. How about occlusion, pre-existing restorations, position or rotation, and then some want to talk about, the shade, the prep. Don't go too crazy with this one, because between the blockout techniques and the opacities of the ceramics, I wouldn't worry too much. I know some people talk, well, I'm going to prep 3/4 of a millimeter if I want a 2-shade difference. And if I want a 3-shade difference, I'm going to prep a millimeter. If you can measure that while you're prepping, God bless you, because I can't. So, but you need to know the fundamentals first, okay? So one of my art teachers once said, and I thought this was great, one of the things the masters have in common is they never tire of re-engaging the fundamentals. And the fundamentals are key. You keep reading. If you think you know the fundamentals, go back and revisit them some more. They're that important. And what's the number one fundamental prep design? Just make enough room for the restorative material. That's it. It's a mic drop. That's it. That's all. Bottom line, we're done. Simplicity. Types of anterior ceramic preparations. We have the no prep, which we know about, right? No prep veneers, minimal prep veneers, standard, no incisal reduction, standard prep, incisal reduction of different kinds, whether it's a chamfer or just a bevel. These are the ones I do all the time. I rarely do the others, maybe minimal a little bit, but I just don't get those cases. And when you're re-restoring people, you don't get those options. And most of the dentistry we do now is re-restoring, isn't it? So the one change I would make is I would always do a little bit of incisal reduction, because that lends it to a better aesthetic result. Burrs, your armamentarium. Depth cutting burrs. They're all different kinds of depth cutting burrs. From the multiple tiered, all that. The one all the way on the left has a chamfer at the end. Okay. For me, it's not like if I could only use that burr to prep, it would be worth it. I can't only use that burr. I need to use a chamfer burr next. So I really don't care if it's rounded at the end or not. So to me, it's a nice burr. I think it was Dr. Winter who invented it. Good idea, but it just doesn't work in my hands any different than the others. A chamfer burr, medium or coarse, and I like this burr a lot. This is a 2-grit system. It's a coarse and a fine. The fine is at the tip. So you know what that means? I don't have to go back and finish my margin, because my margin was cut with a fine diamond. So that's a really nice, again, I don't need 2 burrs when I have one. You need a concave burr, so you need a football. And then these discs are finishing your preparation. I always need some kind of trimming, either for the smoothing on the root or something else. So I always have some of these, but this is it. This is my armamentarium. Nothing too difficult. The one tip I would give you is, you want to prep efficiently, use new burrs with each case. Use new burrs. Don't use old burrs. Use a new burr, and you will fly through preparations quicker. Less time in the patient's mouth. They love you. Less trauma to the teeth. Use new burrs. Right? Okay. So the workflow is simple. Recontour the arch if you need to. Depth cuts. Prepare, including decay removal, buildups, whatever. Refine. So here's an arch, and here's the crookedness of it. We need to recontour. I took my sterile flare marker from Darby, sterile, and you're going to use a burr that imparts the shape of the surface you want it to be. You want the linguals to have concavity, right? So use a football, don't use a straight burr. And then you're just going to sweep along it and create the concavity. On the facial, you're going to use a regular chamfer burr and just recontour the extra. So then when you're done with the prep, or I'm sorry, the recontouring, you have created the ideal arch form. Now you treat it like you had the ideal scenario and put your depth cuts in. Start with this, you go to this, arch before, arch after. As far as depth cuts, we are taught 3, and we're taught to put some of the inside the ledge. First of all, don't put any inside the ledge because you might be lengthening the tooth, and why are you putting depth cuts in? So I always prep the facial first, or if you put it back in the arch form by recontouring it, you've already shortened it. You don't need more depth cuts. So I would really think twice. I would measure the tooth to make sure the tooth is short enough in preparation. Meaning if you want an 11 millimeter tooth, you want about 1.5 millimeters shorter in the prep, okay? So don't necessarily have to do that step. But I do it a little more efficiently. Those burrs, depth cutting burrs, are very, very fast to use as opposed to a chamfer. So I put depth cuts and then I put depth cuts in between my depth cuts. By removing more tooth structure, the chamfer burr flies through the rest of the tooth structure. So more depth cuts faster than prepping with a chamfer, and you just get a more ideal reduction. Prepare, refine. So after I've done the gross preparation, this is where those discs come in, okay? 3M discs, and you've smoothed it. Now, one of the things with a smooth prep is on the front, you want more of a flat facial. Because think about the contour of the tooth that you want back. You don't want a round facial. Light reflection is going to be crazy. So you need more of a flat surface. You also want a tapered neck. Why do you want a tapered neck? You want something like this. Because think about it, what do the line angles of a tooth look like? Do they go straight up or do they taper nicely? If you don't give the technician room to bring the porcelain in, they're not going to be able to do it. And also, I always take diamond strips. If I'm not breaking contacts, I always take diamond strips between the preps prior to any impressioning or scanning. And I always do this after I take off the tabs. Finishing the interproximal walls. This was a case I thought was going to be really easy. I thought it was no breaking of contacts. I got in there, the guy had all interproximal decay. So I had to prep him like this. But then this is really great for the discs. You go on the mesial and distals and make sure there are no undercuts. Everything is smooth. And you really smooth this up. Because the biggest thing about smooth preps, you have no insertion issues with the permanent restorations. Unsmooth preps, have fun. You'll be adjusting some preps to put the teeth in. Reduction guides are really great. Again, I use a reduction guide where I can do multiple things. I know there's a bunch of them out there. But I prefer the silicone because I can prep against it. If I put it in and I don't say I have enough reduction or I want it in my margin somewhere specifically, I can do it with the guide in. I don't have to take it out. And if I don't have enough reduction, I can put the football in there and get it. Also on the facial, I can get it. If I see I'm shy, I can just leave the index in and prep. I don't have to take it out, grind, put it back in like some of the other indexes. It doesn't make sense to me. Do it efficiently. So Micro makes these really good prep indexes that give you both the buccal and the lingual contour. I really like them. You can pull up, they cut it halfway so you can pull apart to make sure you have from the mid portion of the tooth down to the gingival. You can make sure that reduction is adequate too. And they're just really good guides. So if you're getting this from the lab and you're not using them, you're making a mistake. It's a great, great tool. So I'm using just a palatal prep guide in this particular case to show some things, but here's before I'm trying it in. You see, we're adding the length a little bit in certain teeth, but not so much in others. Here's the final preparation. And the great thing is you can visualize. The key is learn to visualize. You're visualizing where the final tooth is going to look like. Have you reduced enough? If you can kind of see this, you can understand if you've reduced enough. And there's your final preps. Okay. An alternate method I've seen people do is using your diagnostic wax up. So you put your wax up, you put the temp material in the wax up mold and you put it over the teeth. And you can obviously see if it's not right, you can add to the length. So this is a good thing. You can see before. But then people use this and then prep with it on. To me, I don't do it because number one, it's a waste of material, number one. Yeah, it might not be that expensive, but it's still a waste and a mess while I'm prepping. And number two is I find that if it bulks the tooth out more than I want the final, then I under reduce the tooth a little bit. So if you're recontouring using your prep guides like I showed you, I don't see why you have to waste the material, but some people love this technique. It's just not for me. Opposing arch alert, always know that teeth are in a position for a reason. And if you look at this canine, it's flared out. It's got a big embrasure. There's a reason for it. And it's not because that canine wanted to be like that. It's because look at the lower teeth. Look at that bicuspid out further. It's just not in the right position. These things have to be adjusted. This is why it's very important to do a comprehensive exam, discuss other treatment options like you really need ortho. I don't want to do ortho. Okay, well then these, I want to tell you what your expectations should be. Because if you don't meet their expectations, guess who's going to get blamed? But you have to explain things beforehand, okay? Also, flush interproximals. When I'm prepping from one tooth to the other, you want those interproximals flush. If not, you're going to have insertion issues. If one margin's out facially more than the other, and you try, sometimes those veneers just don't go in. Flush interproximals. Diastemas between the teeth, always put cord in, protect that tissue. That tissue, if you look at it wrong, it will recede. Protect the tissue. And then you want to prep down to the cord, which will leave you about a millimeter, maybe a half millimeter to a millimeter subgingival. And then they come out of the tissue and hold that papilla in place. So a thinner burr I like to use in these cases because I don't stand a chance of hurting the tissue at all. Okay. And if you don't go through all the way, you will have a food trap. So you need to go all the way through to the lingual line angle, the mesial or the distal, well, mesial in this case, line angles, okay? Here's diastema case. Also with diastema cases, they have a new hygiene protocol. And they need to know about this, so they're gonna come back with root decay. And what it is they need to floss in an S shape, okay? So when they go in, they're gonna go by the porcelain and they need to go up along the root. So it's an S shape of flossing. They need to know this, and the hygienist needs to reinforce this every time. I reinforce it like crazy to them all the time. And I just tell them, if you don't floss right, I'm going to make more money off you because I'm going to redo these. So your choice. Okay. Now, before we get into tissue management, we are about at an hour, I think. So we have another 15 minutes, 20 minutes or so. How we doing on time, Gabrielle? Or we okay? I haven't heard.
We are, it's 5:15. How longer do you think?
Probably another 15, 20.
Okay.
Okay, so I'll just keep going.
Yes.
All right. So let's talk tissue management. I'm a big fan of paste retraction. I've used it ever since it came out. Expasil was the first product that ever came out. It's a great little product. Takes care of the tissue very easily, stops the bleeding. I just love it. I love it for veneer insertions. It's what I do when I veneer. This was a case I prepped. It was a redo of someone's case. There's a lot of junk underneath the gums. The tissue was bleeding like crazy. Expasil for about 3 minutes, rinse, and this is what I had to take an impression of. Made it very easy. Okay, let's talk about provisionals. They have a purpose. Use it. It's a preview of the final. Okay, preview of the final. They should be functional and aesthetic. For me, before I put provisionals on, I like to use Gluma. It's a nice desensitizer. You're injecting Luxatemp Integrity, putting it over. It's a direct temporary technique. I don't take these out. Just trim and polish them. I use that 8-fluted carbide burr to lightly paint along the margins. I'm then using an enhanced cup, and then these are the Cosmonet polishers, which I'll show you in a little bit later at the final restorations. Okay, and then I paint on a coating of something like Biz Cover, which is these glazes, so you don't have to polish the facial, and it gives it like a porcelain-like shine. Take your measurements off your temps. Check your overjet. Make sure it's where you initially planned it. Take your lengths. Make sure it's where you initially planned it, or adjust it. And that's why when you want to have the patient to come in, they always come in on a post-op, we check their speaking.
55.
And I can see temps are a little too big. I don't like them. I'm going to sunderize them. And I typically don't worry about S sounds. I know people talk about it. I don't worry about it because as long as you don't bulk out the cingulums or make teeth too long, you're not going to have an issue. And if you have minimal issues, usually people will accommodate. If someone comes up with a temporary and say, "Why my S's sounded a little funny first," I go, "Let me know in a few days." And I almost never hear from them. So as long as you're not violating what they already had too much, you're going to be fine. So I don't really worry about it. So what goes to the lab? You know, pictures would be nice. Shade, your prep shade guide. And this is why, because porcelain looks different when you have a tooth behind it. Okay, pictures with the shade guide of the temps to know what the patient is thinking or what color you want versus what they're wearing. Smile pictures don't hurt. And these are the things: final impression, opposing impression of the temporaries, very critical for them to follow. It's different a lot of times than the diagnostic wax up. So just don't sing your diagnostic wax up back and say follow it, because the temporaries will be a little different. And of course, your stick bite, face bow, whatever you want to do. Provisionals and tissue health. If you have a interproximal part of the of your preparations, like you're closing a diastema, make sure I always open this up so there's no tissue impingement. I always leave it open. I don't impinge on it at all, so that tissue comes back very, very healthy. And this is the burr I use. Okay? And remember, greater risk of recession if they have deeper pockets. So don't impinge on that tissue. Send the needed information. Don't send anything they don't need just for the heck of it. And what shade do the patients want? You know, doc, I want my teeth white, but natural. Okay, that's kind of like crazy, but that's what they want. So you want to pick a shade, and here's the truth. Some might not agree, but shading is very simple for a smile. These are the shades, and if you want a little more natural, this is the shade. And the key is the opacity of the ceramic used. Okay, so the best results seem to come with a high value ceramic with a medium opacity. So you have a little bit of translucency built in, little subtle facial texturing, and you're done. There's no crazy color mapping. You just don't need it. Pescatore Advanced Shade Guide. I made this as a joke, but you know, how often do people like something like this, right? So I just say, if they really go crazy, I want white, I just tell them, I'm going to take a picture of your head next to the toilet bowl. And they go, why? Because that's the whitest it can be. And they kind of go, yeah, no way. I go, exactly. And then we talk about it, and you know, we talk about it in a friendly fashion and joking fashion, but they got to know the chiclet doesn't look good. And always be thankful and communicate. So after they're prepped, they come out, and this is waiting for them. And then they sit at the front desk with my office manager, and she goes over and has written directions for them how to keep those temporaries healthy. Okay, let's talk about adhesion, and then we'll wrap it up. So it's how to make it stick. This is a great resource for people who do adhesion and are into cosmetics. Michael Miller of Reality has created this, and during the pandemic, he's offering you to sign up for free. I would take advantage. Rates every product. I am on the editorial board. Probably just because I'm from Jersey, you needed a Jersey guy, but you know, you got some really well-known people on that board and evaluating products as well. The flow chart's simple. First, you have your prep, but if it's deep, I would use something like a Theracal. I find it invaluable for those deeper preps where I'm worried about sensitivity or maybe even a pulp exposure. It's a great, great product. I think it saved a bunch of my patients from root canal at least. And then you're going to rinse with cavity cleanser, chlorhexidine. Clean the prep thoroughly. And from there, you know, you do your rinse and dry, and you're going to do a two-step etch, enamel, and then the internal part. And this is your etch and rinse, your total etch technique. From there, and I love this etch because it's a high viscosity, it stays put, so it doesn't go on the dentin if you didn't want it to, which we'll talk about in a second. And then from here, after you rinse and dry, you're going to put a wetting agent. And I use Aqua Prep, because you know the dental tubules will stand up and will accept your adhesive, which you're going to apply. And here's Albon. And from here, you can either do directs and cure it, or don't cure it and put in indirects. And that's different from the universals or what the self-etch systems, because you're only etching the enamel. It's a selective etch technique, and that's where the high viscosity etchant is very valuable. And then after you rinse and lightly dry, and the two surface needs to have a little glisten to it. It cannot be dry. You apply something like a universal adhesive like Albon Universal. And the great thing is that once you lightly evaporate evaporate the solvent, you cure it so the dentin is sealed, and then you can place an indirect because of the very low film thickness, or direct. So this is kind of the way everything is going, the way I'm going, and making things a lot simpler than the above approach, which you can see has a lot more steps. So insertion of veneers, provisional removal is simple. Slice them and crack them off. Unless you temporarily cemented them, then you can probably pop them down. But I just slice and crack them off. And the one thing is, people always say, oh, you put them on, you don't remove them, the tissue. No, look at the tissue. If you put a nice disinfectant under the tissue and polish and don't have overextended margins, your tissue comes back beautiful. I still will put, and then you're going to try in your restorations, of course, run the diamond strip through, but I will then go and put the Expasil, okay? Very valuable. I don't pack cord. It stops the bleeding. The tissue just stays beautiful, and I'm not worried about any bleeding during the process. Now, if you're using, Emax or something like that, or still Empress or one of those others, I put it in a clay, and then just like the lab does it, and then I do all my process where I clean it out. It's already etched. You're just cleaning it. I used to use phosphoric acid. You might etch it. I've been using Zirclean ever I got it, which has been probably close to 10 months now. So much easier, and it's typically meant for zirconia, but Michael Miller Reality is showing it increases bond strength for almost all ceramics. And then you just, after it's dried, you apply your silane and you're done treating your teeth. Nice little method. If you do want to bond your zirconia, best thing is to sandblast it, use Zirclean and then clean it. And then something like use a zirconia primer. I use Z Prime Plus. And all a zirconia primer needs to have is just know it has MDP. You don't have to pronounce it. I have a chemistry degree in my undergrad. I don't even want to think about pronouncing these things anymore, but MDP is the key term. That's the key ingredient to bond your zirconia. Adhesive cement system. This is my cement system of choice. I've used a ton over the years. But the key thing, first of all, I love the system. I love when they can keep everything in a nice box. So I don't have to go get things or have things in different places. It has everything in a nice box. Their silane is 2 steps, but Michael Miller has shown it's shown some incredible bond strength because it's 2 separate bottles as opposed to 1, which could degrade. Another thing is the highest filler content in these cements makes it it's a very viscous cement. I love it because I can put teeth on and they don't move and it's not messy. I can clean things up very, very easily. So the steps are clean the teeth off, selective etch and rinse, 2 coats of the adhesive for 15 seconds per tooth. This is all bond universal. Remove excess, use air dryer for 10 seconds and cure. So here we're cleaning the prep, putting it on. Okay. And if anything, I over clean with cavity cleanser, that's for sure. Self-etching just the enamel. Use a high viscosity like the Bisco etch because it won't drip on the dentin. 15 seconds, rinse it off. So it should look like this. I do 1 set at a time. I don't do too many so I don't over etch. Okay. Application of the adhesive, 2 coats. Okay. Make sure it's moist looking and then you're going to cure. Air dry, obviously, the solvent, and then you're going to cure. Here it is, and then we cure. Resin cement, here it is. It's just such a nice viscous cement. I can't stress to you, to me, the watery cements just don't cut it. They're too messy, too wasteful, and the restorations will move. So once we're putting it in, it's just a wipe of the brush and the margin's clean. And then I use a 4mm tacking tip, not the smaller 2. I use the 4. I cure it for 5 seconds and those things stay in place. Sometimes I put in one side, sometimes I put them all at once. It really how I feel that day. But a nice conservative technique is 2 at a time, 2 front ones, then do one side and finish the other. After you're done, you want to floss the interproximal cement out of there. So I floss gently, and then I put the floss in one of the sulcus, and then I cure it. And I do this as I go interproximally. Okay? Now I'm not worried because as I go around from the flossing, you will get bleeding, but I'm not worried because that area is completely cured. And I cure with 2 lights. I use the Velo lights from Ultradent, and I cure on both sides at the same time. Then I go in first because the patient might be waking up a little bit. I use the Cosmonate strips in between, and I polish in between. Then I use that 8-fluted carbide again and just paint the margins smooth. And then I start with my enhanced cups and my Cosmonate cups. And the Cosmonate cups are the flexi cups, and they have flex for a reason. They flex under the gums, they don't tear the tissue. So they're great cups. Ceramic polishers, these are great intraoral systems. They also make great extraoral systems. So try them if you can. And here he is before, and here he is after. Now your practice. Bear with me, another 5 minutes. The key things to understand is sit down and really come up with a vision for your practice. The glitz and the glam and these shiny apps, they all come and go, okay? Marketing tactics will come and go. Relationships will endure. If you build relationships with your patients and with your community, relationships will endure. So really, the most important thing is relationships will endure. I can't stress this enough, okay? There's a lot of short-term little fixes and glitz and stuff. No. Relationships. There's a relationship with everything, right? Everything we do, relationship to the lab, relationship to our patients, relationships to our staff, communicating to those people as well. That's all our profession is about, okay? And wouldn't it be nice if we communicate? Too often we don't, but why should we? Because when you have a patient come in like this on a routine basis, and they constantly ask about bleaching, or maybe I could do a couple of veneers, you go, you know, let's sit and talk for a while. And you go, let me talk, let me image you. Let me show you what it look like. You have, you know, what do you think? And then you get to do this because you sat and you invested the time and they trusted you. And this, and this. And they get this smile, they have the Vita Shade guide in their mouth, and now they don't. So this is what relationships and communication give you, okay? Not a shiny app. And this is ultimately what I think my career is hopefully about, is when someone comes in like this and puts that kind of trust in me to restore this mouth into this, I don't take it lightly. And this is like an endearing thing to me when someone puts that kind of trust in me. And to think it doesn't change someone's life, it changes her life, but it changed mine that I could help her. And this is what you all can do. We all have the possibility to do it when we sit there and talk to the patient and let them know what we can do for them. So I want to thank Microdental Laboratories very much. I'm sorry I went over, but I'm from Jersey and we talk a lot. And again, I can't thank Bisco enough. I use most of the products they're showing here, and it really, I think, has kept me out of trouble with a lot of procedures that potentially could if you used lesser products. So thank you very much, Bisco, and thanks for that promo code. I'm going to take advantage of it too. Anyway, we discussed a lot of things here today, but bottom line is it's all about the family. Of course, you see my daughter, she has to pose nice. The boys, of course, we goof around. Here she is. She's going off for her MBA to Notre Dame. And of course, she didn't wear retainers after ortho. So now she's wearing Trio Clear. This is a micro product. I've been using it, you know, they're clear retainers. She loves the system. It's great. So check it out. Also, last book recommendation, the updated Aero Splendorizing or Stripping book. This is one of those books I got in the early 90s, along with the Fundamentals of Aesthetics. Great, great book, okay? And then, of course, my son, partner in crime, all that kind of stuff. So thank you very much. I want to just put some contact information for you. And this is my email. This is Dr. Nunez at Bisco, great supporter, and of course, Tim here at Microdental. Thank you all very much. I really appreciate it.
All right. Okay. Thank you so much, Dr. Pescatore. And I know our time is limited, so I like to, let's move over to the Q&A portion. So our first question is, at the end, do you mind going back to the slide of the burrs that you use for your veneer preps?
Nope. There you go.
All right. Next question. Could you please address on how do you clean the preps when they had TBNA when delivering full coverage restorations? Thank you.
I'm sorry, when they had what?
When they had TBNE when delivering full coverage restorations.
Oh, you mean like Tempon Clear or Tempon NE? Is that what
Yes.
the TBNE?
TBNE, yes, correct.
Oh, well, I don't use it personally. I use like Tempon Clear. I use a non-eugenol. But if they're TBNE is Tempon non-eugenol, so it shouldn't technically be a problem. It's the eugenol that typically is a problem with the adhesives. But when in doubt, pumice the teeth.
Okay.
Always pumice the teeth. Some people microabrade, but I think pumice should be fine.
All right. Next question. How many visits does it take to do a typical smile veneer case, say 10 upper teeth?
Well, I have a 2-page handout that patients get. It really just takes 2 visits to do the case, prep and see. But I have a total of 6 visits laid out for them in the handout. The first visit is records, all this other kind of stuff. The second visit is when they come back, they see their diagnostic wax up or model I printed, and I prep them. The third visit is a day or 2 after I prep when they're not numb. That's their first post-op. So that's, what are we on, visit 3? That's their first post-op. The next time they come in is for the final insertion. Is that right? Prep, post-op. Yeah, and then the final insertion visit. And then they have a post-op the next day or within 3 days. So they're not numb, I can check the bite. And then 2 weeks out, they have their final post-op for photos and everything else. So it's really 2 working visits, but 6 visits total. Again, don't rush things, people. We're in a rush. Don't rush. Quality, it shouldn't be rushed.
All right, next question. If patient does come back for seeding of veneers and tissue is bleeding and not adequate, what are you doing for that situation?
Thankfully, I've only had to deal with that where it's been severe a few times in my career. One case, I had to literally isolate and seed each tooth individually, which is a nightmare, but possible. If they're really bad, that's why when my office manager sits with them, they get the thank you bag, they get the chlorhexidine wrench, they are told, if your tissue comes back and it's bleeding, we will not seat your case. So that's incentive enough. And we check with them. But you're going to have those rare people. Sometimes you muscle through it. That's when I use a ton of Expasil. I use a ton. I'll even pack some cord sometimes to give me some additional. But those are those cases where I'll put in a small section at a time. And I've done it. And thank God there's been no micro leakage, no problems. But those people are not on my favorite list, that's for sure.
Okay, great. Next question. Do you typically do ortho treatment for patients before doing restorative work? When they need it, I highly recommend it. And I've had people I've actually refused to do any cosmetic work on before veneers. And I can remember one lady in particular, I remember she had 18 months of braces. She came in for veneers. I could have prepped her, but her teeth were really crooked. I said, listen, I don't want to prep that much of your tooth away. Just, you're an adult. Do yourself a favor, get ortho. So she went and got the ortho after a lot of moaning. And she literally would call me every month just to yell at me. And then after a year and a half, she came in, she was done. I did veneers, and she always tells me the best thing she ever did was ortho. So I really push it. And you have to be very stern about it, and you have to decide whether you really want to prep that much tooth away if they're really that crooked. My recommendation is don't, because when they need root canals later, they're not going to take responsibility for the heavy prepping. So yeah, I think you really need to push those things, and I push them very, very heavily. Great. All right, so our time is limited, so I'll ask one last question. Okay. This last one is, instead of imaging, do you do direct mock-ups in the mouth with composite to show them their new smile? Yeah, I think I mentioned it briefly. I mean, that's definitely possible. If that's your thing,
God bless you. And I do it on very small situations. I might do it very small, but in general, I just feel I like the digital workflow. I like doing the sculpting out. So they have no problem me, taking a scan of their mouth and then doing some mock-up that way. They don't have a problem, say, coming back. But I know, if that's your thing and you use that maybe as your diagnostic wax up, God bless you. I mean, I think whatever works for you. I just don't want to waste the chair time for me personally, but some people love it. So do it if it works for you. Yeah.
All right, great. Well, that wraps it up. I would like to thank you, Dr. Chris Pescatore, for this insightful webinar.
Thank you.
So thank you for our sponsor, Bisco. And lastly, thank you to all the attendees for joining us. And until next time, everyone, thank you so much. Thank you.
Thank you. Take care.